Good morning, everyone. My name is Rajiv Kumar. I'm the Associate Dean for Academics at the All India Institute of Medical Sciences. It's my pleasure to welcome you all, not invite you, welcome you all to the Sarveshwari Memorial Oration for 2022. The orations are a part of the activity of the academic section of AIIMS New Delhi, and I represent the director and the dean here today. The director unfortunately had to be away, and the dean is here to represent the director and the academic section for today. May I request Professor S.S. Kale, the head of the Department of Neurosurgery at AIIMS New Delhi, to begin with the introduction of the orator.
Good morning, everybody.
Recording in progress.
Good evening, Professor Berger. I hope you can hear me.
Yes.
Okay. So in the next few slides and a few minutes, I'm going to introduce the oration. This year will be the 32nd Sarveshwari Memorial Oration for our Department of Neurosurgery and for the All India Institute of Medical Sciences, New Delhi. Now, late Mrs. G. Sarveshwari was born on 10th June 1947. She was the eldest child to Mrs. and Mr. G.S.K. Rao. Now, Mr. Rao was an electrical engineer from Bangalore. She had her early schooling in the Andhra School, Delhi, which is affiliated to the Central Board of Secondary Education. Her father, Mr. Rao, was posted in Delhi for some government assignment. After her school, she did her Bachelor of Science with honors in 1968 from the Delhi University. And she was a student of the prestigious Miranda House College, which is a famous girls-only college in the University of Delhi. She was an excellent student and she stood first in the Delhi University in her master's in botany, which she did after her bachelor's. And for that, she was awarded the Panchanan Maheshwari Memorial Prize for her achievement. Soon after her master's, she got married and settled down to a happy married life. Between 1968 to 1975, she became the proud mother of 3 children. The first symptom of brain disorder was noticed in May 1974 in the form of severe headache and loss of consciousness. Her husband at that time was posted at Balco, which is an aluminium factory not very far from Delhi, at Korba. And the doctors in Korba referred her case to All India Institute of Medical Sciences and our department. At AIIMS, she was diagnosed to have a malignant astrocytoma. She was operated upon on 12th of March 1976 and a radical tumor removal was done. This was followed by radiotherapy. Following the surgery, she made a quick and complete recovery, but the tumor recurred and she succumbed to her illness on 3rd of February 1977. This oration was instituted through a munificent grant by her loving husband. The first oration was delivered in 1981 by Professor Christian Christiansen of Oslo, Norway. Over the years, some of the other distinguished orators have been Dr. Rasmussen, Dr. Jacob Abraham from Vellore, Hugh Cookham, Professor Bricolo, Crockard, Dr. Yoshio Suzuki, Professor Sano, Professor Kano, Professor Sami, Andrew Kai, Professor Fessler, Professor Dashling Pang, and last year, Dr. Sarvadei, who happened to be the president of the WFNS, gave this oration last year from Italy. And this year, we have you, Professor Berger, and I think my colleague will shortly introduce you to the audience. Thank you very much.
Thank you.
May I now request Professor P. Sarath Chandra to introduce our orator for the oration.
1999, he was a president, Society of Neuro-Oncology. 2002 to till present, he has been nominated as America's top doctors, peer-nominated referral index from Castle Connolly. 2006, he was in the joint section of tumors. 2006, he was nominated for the Ronald L. Bittner Lecturer Award. Next. 2006, he was the recipient of Faber Award winner. And again, he was in the board of director of American Association of Neurological Surgeons and then member of American Board of Neurological Surgeons. and then Vice President of American Association of Neurological Surgeons, Secretary, American Academy of Neurological Surgery, President-elect, American Association of Neurological Surgeons, President, American Association of Neurological Surgeons. Next. So he has a huge academic weightage. He's published 726 peer-reviewed articles, being a busy surgeon, which is really remarkable. And most of these articles have created a huge impact, especially in the area of management of gliomas. And in a way, it's coincidental that he happens to be giving this oration, which has been named after a patient who has suffered from glioma. Next slide. Do we have next slide? So he has written several books which have become almost Bible for anybody who wants to know anything about gliomas. Next slide. So these are some of the books which he has published. Next. So he has about 101 book chapters and has published a total of 11 books. Next. Next. So he has given several reputed presentations, including the Pediatric Brainstem Gliomas, Symposium on Instrumentation. Next. And so many others. I think it would be frivolous of me to go on reading each one of them. Next. 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 So, ladies and gentlemen, it's our proud privilege to present to you Professor Mitchel Berger, and without wasting any more time, I will request him to give his oration. Thank you very much. So, Professor Berger, are you online? Can you hear us?
Yes, I can hear you very much. Let me try to share my screen first. So the host disabled my ability to share the screen. So maybe we can try again. You have to let me share my screen. Okay, maybe. Great. Okay, well, can you hear me? Can you hear me well enough?
Yes, we can hear you, Professor Berger. We can see your slides and we can hear you. So you can start your presentation. We are all with you.
Okay, well, I am very, very honored, of course, to give this very esteemed oration. And as you said, it's particularly meaningful in light of the fact that the person whose family dedicated this talk after passed away with a glioma. So I think it's very appropriate that we're going to spend the next period of time talking about being a surgeon who just essentially built a career around glioma surgery. First, though, I want to just acknowledge AIIMS. You know, AIIMS has an incredible reputation around the world. Everyone in neurosurgery knows about the All India Institute. It's very famous. My only regret so far in my career is that I've not been able to visit. And this was my great opportunity to do so, but because of all the things going on in the world, it was very, very difficult, of course. And I just hope I get a chance to come at some point and not only visit, but teach and operate. It would be a great thrill and honor for me. So I want to thank Dr. Tandon very much, Dr. Chandra very much for allowing me to give this talk. I really appreciate it. But it's not going to be the kind of talk that you might expect me or somebody like this to give. It's going to be, basically, it's going to be a story. I'm going to tell you a story about my life and the decision I made when I was a young surgeon against every bit of recommendations to develop a very super specialized, focused neurosurgical practice. in the beginning of a career, we face many, many challenges. And in neurosurgery, as I started to look around, it was like being in a restaurant with a buffet. You don't know which part of the buffet table to go to first. You want this, you want that, you want this. And in neurosurgery, were many, many temptations early on in my career. And as I began to think about this, I realized that no matter what I did, no matter how good I thought I could become, I knew I could not excel at everything in neurosurgery. So I decided, against advice from everybody I've met at that point in my career, Dr. Wilson, for example, other very distinguished neurosurgeons at the time in my country, they all said, no, you should not specialize, especially in one given area of tumors. So I thought about it for a while, and I started thinking about, if I was going to specialize in the field of oncology, could I potentially do everything? And once again, I came to realize that I didn't think I could be great at everything. And I wanted to really be great at what I was doing. I wanted to be the very, very best I could be, and I wanted to make a contribution to the field. And so at that point in time, after my training, my residency, which finished in 1985, I had pretty much decided a few years before that I was going to specialize in gliomas, and I was going to do both pediatric and adult glioma surgery. And so I did that. And that was basically how my career started. I then quickly came out of the pediatric realm because I began to realize that there was a very different need in the adult glioma realm that there was in the pediatric realm. But I learned everything I could from my experience of being a pediatric neurosurgeon and in learning about pediatric neuro-oncology, of how to operate in the posterior fossa, how to operate in the thalamus, how to operate down in the spinal cord. It became very, very insightful to me as a glioma surgeon involving adults. So I began to think about, if I was going to be productive in my career, I had to take a chance, and I had to focus in on one area in gliomas. I had to stay primarily in the adult realm. And then when I started thinking about it, I realized there was still a lot of different things I could do, from the clinical realm to the basic science realm to the translational realm. There was just a lot of things. I could get involved in imaging, in neuropathology, molecular epidemiology, all the things that were critically important to understand how to deal with gliomas. So here I am, it's 1986, and I'm beginning my first career as a neurosurgeon in the academic realm at the University of Washington. And I decided at that point into science side to a translational side. And what I wanted to do, more importantly, as I thought about it, was I wanted to use the experience I had from the teachers that I had and try to develop new surgical techniques for doing glioma surgery. And I had two teachers at that point in time. I had Charlie Wilson, who was a master neurosurgeon, who did very basic glioma surgery. And you could see me as a resident back in the early 80s behind Dr. Wilson. And then when I went to my first job at the University of Washington, I met Dr. George Ojiman, and one day I went to the operating room and I saw him do an operation on epilepsy in an awake patient. And I decided right then and there that I was going to combine what Dr. Wilson taught me, which was to do a maximal resection, and what Dr. Ojiman taught me was to do a resection that was safe and to use techniques I had never learned before, like awake surgery or trying to find subcortical motor pathways, etc. So this is a story about how I took a chance in carving out a very super specialized niche in neurosurgery. And we're going to follow this career, and you're going to see how it evolved and the steps I took to get to where I am today. Now, whenever you do something like this, you need to start by saying to yourself, well, what exists out there? What do we know about what it is I want to do? And it was very clear to me as I look back into literature, starting my career in 1986, that there were only 3 papers that combined some form of functional localization with removing brain tumors. There was only these 3 papers. This is all I could find. So I started reading everything I could read about functional localization. Much of it came from cognitive neuroscientists like Norman Geschwin, who was the first one who really started to talk about connectivity in the subcortical realm and, as you'll see, plasticity. And then there was Wilder Penfield, who was really the first one to begin to modernize the techniques of cortical-based stimulation, direct cortical stimulation of the surface. And so as this went on, and as I started to realize how important it was to maximize extent of resection, it seemed to me that this was a very logical career to build, that I was going to be a glioma surgeon. I was going to try to do very large radical resections of tumor, hopefully one day go beyond tumor, but I was going to try to do it safely. And I was going to write 2 stories in my career. One was how to use mapping to do a maximal safe resection. And 2, how to use all of those techniques I learned in cortical localization and in subcortical localization that I'll show you to build an argument that extent of resection influences survival, it influences progression-free survival, and in the low-grade gliomas, it influences malignant progression-free survival, reduces the risk of malignant transformation. Now, I'll show you a little bit about the work that I did that built those 2 stories. But clearly, this is where I was back in 1986, beginning my career. So, and I would say, just that when I was president of the AANS, I did also talk about the whole concept of safety, because to me, it went hand in hand. If you're going to do a very aggressive surgical removal, you must do it safely, because if you don't do it safely, it doesn't mean anything. So doing both of those and doing them very well was how I built my career. Okay, so one of the first lessons I learned in my career was that function was far more important than anatomy. Now, of course, we need to know anatomy and we need to understand where we are at any given time when we're operating. But the reality is, it made me realize that it was like flying a plane at night. The reason why a pilot can fly a plane at night successfully is because he or she uses radar. And the brain mapping became a radar for me, because I really didn't care about the anatomy. As long as the tissue I was removing was not functional, that's all that mattered. And so function really was more critical than anatomy. So let me show you how I started my career. I went to the University of Washington. I decided to go to a place where nobody was doing tumor surgery. Nobody was writing about tumor surgery. Nobody was researching about tumor surgery. And I decided to go and to begin the career there because I wanted to work with Dr. Ojerman because I really felt that I could learn some interesting techniques from him. And as you can see, I wrote a lot of really important papers early on in my career at the University of Washington, which helped me to realize how critically important functional mapping was at its basic level, cortical mapping. And I began to analyze as I developed more time in my career about how extent of resection affected outcome of our patients. So this was kind of the beginning, and you can see that I was a very avid writer. I would do two things in a given week that were unusual. One is that every Tuesday night, after operating on Tuesday, but not operating on Wednesday, I would stay awake all night. And I did this for 15 years. I would stay awake all Tuesday night, and I would do nothing but write papers by myself while my family was asleep. The next day I would get up, but I wasn't asleep. I would come into the morning after being up all night, and I would go to clinic, and I would stay there until 3 in the afternoon, and then come home and go to sleep, and then get up and operate on Thursday. So I did that every Tuesday night for 15 years. And then secondly, every Saturday, I would leave the house at 5 a.m. and then I would come home at 3 p.m. And I spent all day Saturday at the office just writing, looking at every piece of data I ever had. And I would write. And I would have a team of people that work with me, and we would go over every manuscript and we would write. I was obsessed with writing because I felt that writing was the only way that you could be honest about your work. You had to look at your data, you had to report it, and you had to do it honestly. So to me, this was a very important lesson, doing those two things. But of all the papers I wrote during that time, this was the most important paper. And I just want to take a moment to discuss this because I think it's probably, when I look back in my career, and I am now almost 70 years old, and I look back on my career, I've been operating for 38 years. And I have a list of the 5 most important papers I've ever written personally for me. And this is one of them. And I won't say it's my number one paper, but it's one of the top 5 papers. And why is that the case? Because at this point in time, this was the largest experience ever in the history of neuroscience to document where language localization existed in the cortical realm in the dominant hemisphere. This was it. And basically what we did was we identified every time we stimulated a site, for example, 62 times at this one site in the superior temporal gyrus, and the likelihood of having a stimulation-induced language deficit. And then we built these maps. And this was a very, very interesting process. And it taught me something, and I didn't realize it, but I'll come back to this issue. It taught me a lot about why the brain is plastic, why there is plasticity. I'll come back to this concept in a little bit. But of all the things I learned in this study, the most important thing I learned was the 4th bullet point. It was that there was variability in language localization. So as you'll see as this talk goes on, I've now done just a little bit over 3,000 awake language mapping craniotomies in my 38-year career. In no two patients have I ever found, and that includes the case I did today, followed by the motor mapping case I finished a few hours ago. But I've never seen two people who have the same localization of naming, reading, and other language functions. That's very different than the motor system. Today, when I was mapping the motor cortex and then the subcortical system, it was very standard. I knew exactly where the motor system would be. It's the same place in everybody, as is the sensory system, as is the visual system. But language is very, very different. And this lesson stood the test of time, and I'm going to show you how I proved to myself later on in my career that indeed this was the case. This was true. Okay. Well, this is a famous song in San Francisco. There's Clint Eastwood, who filmed many movies. I live very near this street that he showed. And will shine for me. So after finishing the University of Washington, I had left my heart in San Francisco as a resident, and I was given the opportunity of my life to go back and to become chairman in San Francisco and to continue to build upon what I had done in Seattle. But yet there was much more to do. And there were many important studies that happened over the past many years. And I'm going to take you through the more relevant studies because it will show you the story of how I learned as I went along. I taught myself, and I taught myself primarily because I made mistakes early in my career. And I learned from my mistakes, and I developed the tools and the methods to help me correct my mistakes. So I'm going to divide these into three categories. One is technical advances. Another is some of the clinical mapping studies that I've done through the years. And then I'm going to just touch on a little bit of the contribution I've made in extent of resection and outcome. So one of the first things I realized in mapping the motor system was that it was very, very difficult to rely on anesthesia to identify the motor movements. And I needed a more precise method. So I developed an EMG system, and we used this for a sleep motor mapping to allow us to identify motor movements with cortical and subcortical mapping of the motor system in patients who are asleep without having to actually see movement of the muscles. So we could see very, very tiny movements of the muscles that are not often seen in the naked eye, but this was a very sensitive system that combined EMG with cortical mapping. Then, because of a patient I had operated on early in my career where I removed a cortical tumor, but the patient woke up with a preserved function of his arm, but he lost function in the leg because I didn't know how to map the subcortical system. There was really no precedent for doing this. So I had a stimulator system. It was a very raw unit before we had the Ogeman stimulator. And we used many different frequencies, many different pulse durations. And eventually we came to a technique with low frequency stimulation with 60 hertz, 1 millisecond in duration, using a biphasic square wave pulse, that we could identify subcortical motor pathways by stimulating axons in white matter. This had never been done before, at least in the glioma realm. I didn't have any precedent for it, but it became very, very successful. And In 2004, I described the experience of doing subcortical stimulation mapping using the low frequency technique. And then in 2019, I went back and looked at my experience with over 700 cases of subcortical mapping, and I found something that was very disturbing to me. What I found when you look at these numbers is that if I was able to successfully map the cortex and then go under there and find the subcortical pathway, and if I got close enough to actually see subcortical stimulation using low frequency, then I had a permanent risk of motor deficit of 7%. Now you might say, well, 93% is pretty good, but 7% for me was still too high. So in the past few years, I decided I was going to try something different because 7% is going to be too high. And I'll come back to this in a minute, and I'll tell you how I solved this problem. But I first want to touch on the awake mapping technique because we're going to go into this as well. We're just going over the technical advances. And this was the first paper that I published looking at my 27-year experience with language mapping, and then went on to publish a number of papers describing the awake technique in which we use the asleep, awake, asleep strategy to be able to get in there to map, to do subcortical mapping, to wake patients up, to map the subcortical system, as I'll show you, and then to be able to do that and keep the risk at just around 2% of a permanent deficit. And I'll come back to this when I talk about the study I published on negative mapping. But before I go to that, I wanted to finish up the point about the subcortical system, because I realized again that the deficit risk was too high with the standard bipolar low frequency stimulation. So I started to incorporate a technique that Lorenzo Bello, who was my fellow many years ago, Lorenzo started working on this, and he would send me notes through the years, and just like Hugh Defoe would send me his notes about plasticity and how plasticity, he was seeing plasticity. And I would say to Hugh, oh no, I've never seen it. I'll come back to that point because Hugh was right, I was wrong. And Lorenzo was starting to teach me more about subcortical mapping with high frequency monopolar stimulation. And so I decided to combine the low frequency bipolar technique you see here with high frequency monopolar strategy here, which allows you, when you do this with monopolar high frequency stimulation, it allows you, using the settings that we use, to map 1 millimeter per 1 milliamp. So today, for example, I was taking out a right-sided, the second case was a right-sided mesial temporal lobe tumor that went right up into the junction of the capsule and the peduncle. And before I could even see the peduncle, I continued to remove tumor and stimulate with monopolar, and I got to within 2 milliamps, meaning that at a frequency of 2 milliamps, I could get the arm, the leg, the hand, everything to move. So I knew I was 2 millimeters away, and that's when I stopped that resection. And then while I'm doing that, I have these little corkscrew electrodes that are stimulating transcranially, telling me that the motor tract is intact. So today, for example, as I'm stimulating and the neurophysiologist says, you're 2 milliamps, you're 2 millimeters away from the motor tract, I said, well, run the motor evoked potential. Is it intact? Yes, it's intact. Yes, it's intact. So I was able to push that resection all the way to 2 milliamps, 2 millimeters, because I knew the MEPs were intact. So this is what I've now called triple motor mapping. And we published our first experience with this, showing that our morbidity rate was very, very low, which was very, very exciting. I was very happy about that. And it was we only saw one deficit, and it was a 4+/5 deficit with triple motor mapping. We're now going back and looking at nearly 300 of these cases that we've done since I wrote that article a couple years ago, showing again that I've been able to reduce the morbidity now from 7% to just under 1%. So that's great. So I'm very happy with the motor mapping strategy that I have now. Subcortical language, subcortical stimulation, we do it for the motor system, and we do it for the subcortical language pathways, where we can map both the ventral tracts and the dorsal tracts, looking for stimulation-induced semantic paraphasias in the region ventrally, such as the inferior frontal occipital fasciculus. And then we can look for phonological paraphasias with stimulation when I'm in the SLF or the arcuate fasciculus. And this has been very useful. So now I have 4 tests that I do every time I do awake language mapping. I do cortical naming, cortical reading. I do subcortical stimulation of the ventral tract, looking for semantic paraphasias, and subcortical stimulation of the dorsal tract, looking for phonological paraphasias. And those 4 tests keep me within 2% permanent morbidity from language mapping. So that's been very useful. And now with the subcortical mapping of the motor system using triple motor mapping, I'm within 1% of a permanent deficit. So I'm very, very happy with the evolution of these techniques. They have evolved very nicely over the years. They are reproducible. I use them every day, including today. And I now feel very, very comfortable, even at this stage, using these techniques and these strategies to push the extent of resection safely. Now, I told you early on in my career that I learned the lesson about language variability. Well, I had to prove to myself that that was truly the case. So as I started to do more and more cases, I would save every time I got stimulation-induced anomia or reading deficit. I would save that information and I would put it in my navigational workstation, and I would save all those points. And this evolved into a paper we published about 4 or 5 years ago, showing the probability of finding anomia, for example, as well as the probability of finding speech arrest and comprehension disorders versus the variability. So the probability is seen in red. This is where you would expect to see speech arrest, so-called Broca's area, although I'll come back to that because Broca's area does not exist, but I'll come back to that in a minute. The red shows where you're likely to see speech arrest, but in the green, you can see speech arrest simulating Broca's area anywhere, even in the superior temporal gyrus. You can see comprehension deficits, typically in the area overlying Wernicke's region. But turns out in all these green areas, you can still see stimulation-induced naming deficits or comprehension disorders. So language is variable. Now, another thing that this strategy has helped me to do is when I deal with deep-seated tumors, like I was doing a very deep-seated glioma near the ventricle this week, and I had to do this in the dominant hemisphere, so I had to do it awake. And so for me, the closest point to the tumor is based on the equator of a tumor and the closest point of the equator to the surface. So in this case, for a mesial temporal tumor, you might think of coming subtemporal. You might thinking of coming down the Sylvian fissure, but actually I would do it transcortical, directly into the tumor, because this is the closest distance to the equator of the tumor. Now, the only trick here is you have to map this area, and on the dominant side, you have to know that it's safe to go in there and do that. And so this cortical mapping strategy has, as well as subcortical stimulation, has allowed me to be very safe with subcortical trajectories into tumors. So the morbidity issue for all of these technical advances has been huge. In fact, we've been able to show that with stimulation mapping, we've been able to decrease our deficit rate to half than when you do not use stimulation mapping. So if you're going to remove a glioma, it now becomes a standard of care to do this with mapping, because without mapping, you're twice as likely to have a permanent deficit. Okay, let me go through some of the clinical studies that we developed through the years. I set out, before I stopped doing pediatric neurosurgery, I did a lot of language localization in children. And basically what I learned was the same map exists in children much past the age of 4 that we see in adults. Sometimes between the age of 4 and 10, we have to use a subcortical grid. But for the most part, any child over 10 years of age, we do awake. Sometimes we have their parents in the operating room with them. I know that sounds strange, but the parents don't see anything. They don't hear anything. They're just with their child, helping them to get through the mapping. But the mapping that we've seen in these kids is basically the same as what we see in adults. So no problem there. This was another one of the top 5 papers I've ever written. So again, if I think about what are the most important papers I've ever written, this is one of the very top 5 papers. And basically what it did was, it was a study that I published in the New England Journal that, to me, identified an evolution of the technique. When I first learned how to do mapping, I would do very large cortical exposures because I wanted to find a positive site to convince me that it was okay to use the mapping to do the tumor removal. But as time went on, I would do many cases that had negative mapping. I couldn't find a positive site for anything. I knew the stimulation was working. I had no problem with my electrical physiology and the feedback I got from the stimulation, the after discharge potentials, but couldn't find any function. So I would do the removal anyway. And I followed those patients with the following question: is it okay to do a removal if you have negative mapping? Can you rely on negative mapping? And the answer was yes. I didn't know this when I started, but I had a good feeling that I would be right about this if I did it. So over many, many, many years, I collected these patients where I looked at all the maps, and I saw that in many of these situations, there were negative maps. So for example, it's difficult to see because of the numbers, but you could see in a place like this, in a glioma patient, 100% of these stimulations turned out to be negative in this study. 100% were negative. It just so happens that there was a clue here about plasticity, and I didn't understand it at the time, but I'll come back to this in a minute. But it has to do with the fact that when you're dealing with chronic lesions in the brain, there is a chance for rewiring for cortical and subcortical, but mostly cortical plasticity. And so that's why a lot of these cortical sites were negative. So based on that, I would remove tissue that did not have a positive map. And even though I saw deficits in the beginning, by 6 months, I had the final place where these patients would be. So in other words, no matter what they looked like after surgery, 6 months later, I only had less than 2% permanent deficits. They got better. Just like the patient I operated on yesterday who's awake, 3 hours after surgery, he was perfectly intact. It was a big left temporal lobe tumor. But today, he can only tell me one object. He has trouble comprehending. It'll get better because all of the pathways were preserved. So it'll take 2 days, 3 days. It'll get better. But certainly over this time frame, it'll return because there were no positive sites cortically or subcortically when I did the resection. So it's okay. I feel very confident in his recovery. And here's why I feel confident. Because we've been able to prove that it's common after surgery to see transient aphasias. So for example, pre-surgery, many of these patients who have no deficits, 2 to 3 days later, fluency is off, comprehension, naming, repetition, terrible. But by 1 month, they're mostly back, just like we said in that previous paper. And by 6 months, they plateaued out. So you have to be prepared, like I was today, when I went on my rounds and I saw the patient who the day before was fine within 6 hours, 3 hours, then all of a sudden things went terrible. And we'll see how he is tomorrow. But certainly by the weekend, he'll be much better. What about right-sided language? Right-sided language is absolutely similar to left-sided language. So when we see patients who we know have right hemisphere dominance when they're left-handed, the language maps are the same. We don't see anything unusual. Now, I want to talk about the SMA syndrome. This is another key clinical study. Early on, I wrote a paper describing this syndrome. I called it the supplementary motor area syndrome. And it was based on the fact that when I removed the area in front of the motor cortex, especially if I took out the cingulate gyrus, that in patients who had left hemisphere surgery, postoperatively, they were mute and hemiplegic, but it always resolved. Now, I didn't understand the pathophysiology of this early on. I just reported it. It was one of those studies I did late at night or on the weekend. I just reported these cases. There were 6 cases. And I saw it on the right side, but in a right-handed person removing the right supplementary motor area, I didn't see any trouble. I didn't see mutism. They were able to talk. They just had a left hemiparesis or hemiplegic. But recently I went back and in October of last year, I published the compendium article revisiting the supplementary motor area syndrome. There had been some talk about how the frontal Aslan tract is responsible for the supplementary motor area syndrome. Turns out it's not responsible for it. So the point of this paper was to show with postoperative DTI that we resected the frontal Aslan tract. And unlike it was thought that this could be related to that, turned out that the Aslan tract can be removed without a problem, and that it's not associated with the SMA syndrome. So the reality is that the SMA syndrome is due to how much of the cingulate gyrus you remove, along with going back to the pre-motor sulcus. And so I think now I can pretty much predict who's going to get an SMA syndrome based on whether I go back to the premotor sulcus and take out part of the cingulate gyrus. But the good news is everybody recovers completely. As long as you're able to stimulate the motor tracts at the end of the operation, everything comes back, including speech. Well, Broca's area. I said to you, I wanted to get this out there because we have a paper that we submitted to Nature Communications. It finally got rejected from Nature Communications. It's now been accepted to the Journal of Neurosurgery. But basically what it shows is a series of patients who've had resection of Broca's area. That's Brodmann's area 44, where we've removed this in patients who we stimulated the area, had speech arrest, but they recover. And they recover in a way that's really interesting in the sense that the Broca's area, or the area that's contiguous with the face motor cortex and the dominant hemisphere, is really a planning station. It's a planning station, just like the supplementary motor area is a planning station. So if you remove the SMA, patients recover, and they recover because when you do functional MRI, the opposite SMA lights up. If you look at Broca's area, when we recorded off of Broca's area, we can see active when the speech cortex is silent, and the speech cortex active when Broca's area is silent. And Broca's area fires before the face motor cortex. So therefore, it's a planning station. So when you remove it, patients are hesitant. They're also somewhat dysarthric, but it always gets better. So you can remove it. And this is a good example of stimulation-induced speech arrest in this blank number, that when I stimulated the patient awake, she could not talk. I then removed the area, as you can see, and afterwards she was very hesitant. Speech was dysarthric, but it returns in about 2 or 3 weeks. And so it's not something that we need to pay attention to anymore. We can remove Broca's area just like we can remove the dominant face motor cortex, because the contralateral side takes over and fixes the facial droop over time. Bilingual language. Many of you are bilingual. And when we've mapped patients who are bilingual, what I've learned through the years is that if you learn your second language before you become a teenager, you're more likely to have 2 different sites for the same language function, like naming in Spanish and English, 2 different sites. But if you learn it after adolescence, when you're in college or a young adult, they're on the same site. So the bottom line is, when we see patients who are bilingual or multilingual, we map them in each language, especially if they learn their language early on before adolescence. Here's the point I wanted to make about plasticity. And again, in the beginning, Hugh Defoe, who was another fellow of mine who came to the University of Washington and spent several months learning the techniques before he went back to France, we always had very close communications, and he began to tell me about plasticity that he was observing. And I would say, well, what is it based on? And he would say, well, in a couple patients, he would come back years later and he would map an area that he had mapped before that was positive. And then when he did it again, he didn't see it. So he said, why don't you go back and look at your experience? Because I'm about, I don't know, not 20, but maybe 18 years older than Hugh Defoe. So I have more experience with patients who have recurrent tumors. So I went back and I looked at these cases that I did, and sure enough, I found exactly what he said I would find. So for example, in this patient that I mapped, I found these functions here, and then when I went back and reoperated and remapped the patient, I didn't find any function. And this was 32 months later. And so basically what I saw was that in 40% of my patients who I go back and remap, function moves away from that site. Whereas function never, except in this one case, never moves into the site. It moves away from the site. So it was very, very interesting to see and to now believe that cortical plasticity can and does occur in adults. And why is it important? It's important because if you map something that is functional, leave it alone. And then if the tumor recurs or when the tumor recurs, you can come back and you have a 40% chance of being able to remove that. And so that's very exciting. And that was a new lesson that I learned. Another thing that I learned from this technique is that, and I think today was a really good example of a patient who had a tumor that was partially removed because the neurosurgeon said, I think this is inoperable based on where it's located. And so I've now put together a series of these cases that were said to be inoperable that we reoperated on using functional mapping, whereas the other surgeon didn't do that. And sure enough, we were able to achieve extensive resection that were significant in these patients. Why? Because using mapping allowed us to find that there was no function where you thought there was function and to remove that safely. So it's helped me to not think so much about inoperability based upon preoperative imaging. I never, ever look at a preoperative functional MRI or MEG or anything and say that's going to be functional, I can't operate on it. I talked about intrinsic tumors of the face motor cortex, how we remove them from the dominant side as well as the non-dominant side. This is the first paper I reported showing that you could remove the non-dominant face motor cortex and it repairs itself because the other side takes over and vice versa. So we do that routinely now. I never thought in my career that I would remove part of the motor cortex. Well, this is part of the motor cortex that you could remove. Just like I never thought in my career I would remove Broca's area. But now I know we can remove it, and we do remove it routinely. Working in the cingulate gyrus, I came up with a naming system with different zones of the cingulate that allow me to approach them in different locations. So for example, for zone 2, sometimes I have to do an SMA resection to take off zone 2. And for these zone 3, zone 4 tumors, I come back through the parietal lobe and work under the motor cortex, mapping the motor system here to remove these tumors. And so the cingulate from the very back to the very front is very resectable because it has no functional pathways in it that we can detect. Parietal lobe is very interesting because in the non-dominant side, we map praxia. We map patients' motor skills, fine motor skills, while we're doing that mapping in the non-dominant side. In the dominant side, of course, we map inferior parietal lobule for language function and subcortical language of the SLF and the arcuate fasciculus. This is the paper I wrote on removing frontal operculum. Again, very similar to what I just told you about Broca's area, that the frontal operculum with Broca's area can be removed and you don't pick up new deficits. They're very, very few and they're very mild. They're mostly in the form of dysarthria. This is a paper that I wrote not that long ago about removing tumors in the primary motor cortex. Interestingly enough, in the beginning of my career, I did these patients asleep. I had very worrisome deficit rates. I then started doing patients more awake. And I published this paper showing that there were still deficit rates that were unacceptably high in the awake setting. So now I've gone back to doing all of these tumors with patients asleep with triple motor mapping. And doing them asleep with triple motor mapping allows me to get within 1 or 2 millimeters or 1 to 2 milliamps with the high frequency stimulation in a way that's much more accurate than doing this awake. And in fact, recently in the Journal of Neurosurgery, I think last month, Lorenzo Bello wrote a beautiful article about how he now does motor cortex tumors. He does them all asleep. And, you know, it's unusual for him to do awake cases. He talks about when he has to do awake mapping, when patients sometimes have a deficit. He finds maybe there's a little more sensitivity with the monopolar high frequency technique. But I do all my motor cortex tumors asleep now. And the key to all of this stuff is to make sure that you're not transecting subcortical pathways. And this is a paper that we recently had accepted to the Journal of Neurosurgery. It's actually, this is going to be the cover art for the journal that'll come out in a few months, which shows exactly the point of how cortical systems are plastic. They rewire. You can remove this, but the trouble you can get into is if you do not map subcortical language here. This is how you stay out of trouble, is you map subcortical language. And the cortex, in all of these cases, the cortex was silent because it had been rewired. It's the subcortical system that doesn't rewire it. And then finally, I just wanted to talk about my final critical mapping study, which is really about the insula. To me, this has been, I think, one of the most challenging things I've ever done. It's definitely very complicated. It's somewhat risky, although we figured out ways to remove the risk. And I've learned a lot by doing this kind of surgery, and I'm just going to share with you some of these points. In essence, I am a transcortical surgeon. And as I showed you before, when I get to deep-seated tumors, I do these transcortically to the equator of the tumor. In the insula, I do the same thing. So I will map the cortex. I don't split the sylvian fissure. I don't want to injure any of those vessels, the M2 branches, the M3 branches. And then as I go down, I make these windows in this area between these branches, these M2 branches, and then connect these windows together with the uncinate fasciculus. So basically, at the end of this procedure, you're working underneath the middle cerebral branches, behind the lenticulostriate branches, and right where the lenticulostriate branches come down, that defines the middle portion of the uncinate fasciculus, which connects the frontal lobe with the temporal lobe. And that's essentially how I've taken on these insular tumors and done them. And just to go back over this again, instead of splitting the sylvian fissure, I do transcortical based resections. This would be a great case for me to do if I could come to AIIMS and do an awake insular case and an asleep insular case and really show you the beautiful anatomy of the lenticulostriates, the M2 branches, the windows, the uncinate fasciculus, using mapping awake, asleep. It's a beautiful example of how all of this comes together to achieve a really radical resection of these tumors based on transcortical exposure. Okay, if any of you are interested more about the language mapping we've done, this is an article we wrote a couple years ago with my colleague, Eddie Chang, who's now the chair. I trained Eddie as a resident worked with him as a medical student. And this is a really good article if any of you want to read the current model of language organization in the brain that we need to know as neurosurgeons. Now, I'm just going to end with a couple slides on extent of resection and outcome because, you know, from my point of view, this is all fine and well, and this is, we should be doing this, but the reality is if it's not safe, we shouldn't be doing it. And so I've constantly gone back and looked at my own experience, my own morbidity, as well as trying to understand how I've impacted outcome in this disease. This was one of the most important papers I ever wrote. It's one of the top 5 in low-grade gliomas. And we published this years ago. This was the first study of its kind ever that showed if you could achieve a complete T2 or flare resection of a low-grade glioma, the likelihood of a 10-year survival was, in my experience, 95%. And in subsequent years, the French consortium showed the same thing. They showed a nearly 90% 10-year survival. And the Italian group, Marin Scrap, Tamara Us, they showed the same thing, another nearly 95% 10-year survival. Now, we have a paper about to come out which now looks at 20-year survival with complete radiographic resection of a tumor regardless of MGMT in the classic IDH mutated tumor, regardless of MGMT or any other standard markers, 1p19q, etc. And the bottom line is the 20-year survival in our experience is now nearly 88%. So it continues to be a very, very, very durable response rate if you can do a complete resection of these low-grade tumors that are IDH mutated, regardless of MGMT or 1p19q status. This is the other, I think, very important paper in the top 5 as well, and I just published this last year, and this is pretty much my complete experience in high-grade tumors, but what it showed me is, unlike the previous paper I published in the journal Neuro-Surgery, where I showed that if you could remove more than 78% of a contrast-enhancing lesion, that made an impact in survival. But this is a paper that goes beyond that, and it shows you that in addition to removing 100% of the contrast, you have to remove the flare. So you have to do what we call a flarectomy. And if you can remove the flare signal and leave less than 5 cubic centimeters in a patient with a classic IDH wild-type glioblastoma, these patients, especially when they're under 65, you can get their survival. We reported a 50% survival way out here of 3 years, whereas patients who had lesser degrees of flare, in contrast, didn't do as well. So now we know in the glioma surgery realm that supertotal resection of the low-grade gliomas, which Hugh Defoe proved, and in this study that we're about to publish in the Journal of Clinical Oncology, we showed the same thing with supertotal resection of low-grade gliomas. So did Lorenzo Bello in the past year. Now we show that with a supertotal resection of a GBM, removing flare to the point of less than 5 cubic centimeters, that this significantly improves survival for glioblastoma. So this has been a different story that's evolved over the past several years. So last one or two slides, I would just say, for the younger people who are watching this talk, you cannot think that you're going to figure this out when you're early in your career. It's going to take time. But the good news is, as time goes on, you get better and better. And you have to review your experience as you go out there to make sure that as time goes on, you're not dropping off the curve, that you're doing better and that you're learning more. Very, very important. And so now I have a partner, Sean Jumper, who's working with me now very closely, who I've taught all these techniques to. And I'm going to continue to teach and train the next generation, try to mentor as many people as I can, continue to develop new innovative surgical techniques like triple motor mapping. We're working now on the very exciting field of Raman spectroscopy. And as all of you know, Raman developed this famous Indian scientist who developed Raman spectroscopy over 80 years ago. Well, it's now back. And we now have systems that we're using. I used it all day in the operating room today. Beautiful, beautiful delineation of margins, microscopically margins with algorithms, AI algorithms that tell you within 2 minutes whether you're in tumor or no tumor. Beautiful. So that's been fun developing that. I have a new stimulator that I've built to replace the Ogeman stimulator. It delivers both bipolar and monopolar stimulation. And the good news is it's handheld. The tip is disposable. And it's built for countries that can't afford these more expensive stimulators. It will be sold for only a few $100s. So I built it trying to get this all over the world so that everybody could do mapping, that it wasn't the expense that was going to prevent you from doing mapping. Well, in 2020, I stepped down from the chair. My colleague who I taught as a student, who I wrote many papers with as a resident, he's now the chair. We work together. It's very successful. We were ranked last year in our national magazine, U.S. News and World Report, as the #1 neurosurgery program in the country. Because of our academic and clinical expertise, I'm proud to be part of that. And I'm proud to still be doing this, even though I'm almost 70. I think I've got many more good years left to do this. And I really hope that one day I can visit AIIMS and share my experience with my many, many dear friends and colleagues in India, and to learn more about the beautiful, beautiful culture of India, and to get to know more people there. It's a magnificent country. I've been there once, and I can't wait to come back. So thank you very much for allowing me to give you this talk, a personal talk about how I developed my career and the lessons that I've learned by developing a very specialized focused practice. Thank you very much. I will stop sharing. I don't know if anybody's there. Can you hear me now?
Am I audible?
Yes.
So, Professor Berger, it was an amazing oration, and all of us were able to see and hear every bit of it. I
Oh,
don't
good.
think
Thank
it's an oration. I think it's history in making. So we have seen evolution of gliomas, and you being a significant part of it brings us an immense sense of pride that you were able to be part of this oration. Now I will request you to stay there because we have some honors to do. Unfortunately, are not available physically, but we are going to do it virtually. And I will now request my colleague, Professor Kale,
Okay.
I'll now request Professor Kale, HOD Neurosurgery, and Professor Neena Khanna, Dean Academics, to present the plaque to our orator.
Good morning, everybody, and good evening, Dr. Berger. So we will present this plaque, or at least we'll show you on camera what we are going to present, ma'am.
Yeah,
Can you-
I can't see you anymore because I think you have to return being the host.
Okay. So can
If you
we?
can do so.
Can you?
I can hear you fine. It's
All
okay.
this, उनको दिखना चाहिए. No, he says he can't see.
I can't see you. But I can hear you okay.
Okay, you will be able to see us in a minute. Just give a few
Okay.
seconds.
No problem.
No, he still can't see.
Now I can see.
Okay.
Now I can.
So right by my side is our dean, or dean academic for the All India Institute of Medical Sciences, and
Thank you.
this is what she's going to present to you. May I? This is
Wow.
a silver platter. This is the plaque, the oration.
Thank you.
So we will make sure that this reaches you in San Francisco somehow, maybe by FedEx or something.
Oh, that's okay. Thank you.
And
Thank you. very much.
with the plaque goes this something to put on the wall.
Perfect. Yes. Thank you. Wonderful. I appreciate it very much. That's very, very important to me to have a memorandum of this.
Thank you very much, Professor Berger. Ma'am, please. You would like to speak a few words?
Congratulations and thank you for this very, very wonderful oration. Thank you so much.
Thank you. Thank you very much for coming. Please.
May I now request Professor Ashish Suri to propose the vote of thanks.
Well, on the behalf of the Department of Neurosurgery, AIIMS, it's an honor to propose the vote of thanks. We thank the late Srimati Sarveshwari and family. This is the 32nd running oration, and we are honored that we have learned so much over the last more than 3 decades. We thank the AIIMS. It's all been due to the possible because of the AIIMS academic section, the director, the dean, the vice dean, the registrar. We have a lot of, nearly have all our respected teachers and ex-HODs, Professor Tandon, Professor Banerjee, Professor Bhatia, Professor Mehta, Professor Mahapatra, Professor Sharma, and the Chief of Neurosciences Center, Professor Padma, Dr. Kale, Dr. Arvind Chaturvedi, Dr. Gaikwad, Dr. Sharma. We thank the orator, Professor Mitch Berger, for an excellent oration. We have learned so much, and we missed you physically, but we would be looking forward to your visit. And our special guest faculty, Dr. S.K. Gupta from PGI Chhattisgarh, and all our seniors, colleagues, alumni, and friends. We have a full house, and we thank you very much for coming. And we request everyone to stay back for the inaugural function. That will be followed by the high tea. Thank you.
Thank you.
Professor Berger, you can log off now. Thank you for your
Okay.
oration.
Thank you.
Recording stopped.
गुहुकारस्तव अंधकारस्तु रुकारस्तेज उच्यते अंधकार निरोधत्वात् गुरुरित्य अभिधीयते. Guhu means darkness and Ru means the tej, the light which destroys that. So it is our teachers and their teachers who have this light of knowledge and wisdom with which they destroyed our ignorance and brought us into this world. So with this, I pay my respect to my teachers and teachers of my teachers and all the dignified professors, guests, colleague and dear friends to this 24th Micro Neurosurgery live annual workshop. May I now request Professor P.N. Tandon to occupy the dais and grace us with his So Professor P.N. Tandon was May I now invite Professor A.K. Banerjee to come on the dais. Professor A.K. Banerjee was the second head of the Department of Neurosurgery and he was also the chief of Neurosciences Center. And when the center was in its inception phases and the first few years, these two forces primarily managed and made the department what it is now today. May I now invite Professor Ravi Bhatia, the third head of the Department of Neurosurgery. May I now invite Professor V.S. Mehta on the dais, the fourth head of the Department of Neurosurgery and Chief Neurosciences Center. May I now invite Professor A.K. Mahapatra, Department of ex-HOD Department of Neurosurgery and currently Vice Chancellor at SOA, Shiksha and Anusandhan. May I now invite Professor B.S. Sharma, the last head of the department, to occupy the dais. May I now invite Professor M.V. Padma, the current Chief of Neurosciences Center, and Professor S.S. Kale, the current head of the Department of Neurosurgery. So we have all gathered here for the inauguration ceremony of 24th AIIMS Annual Micro Neurosurgery Live Workshop. And we'll start first with the lamp lighting and Saraswati Vandana as is our tradition. So I request all of our guests to sir.
सरस्वती महाभद्रा महामायावरप्रदा श्रीव्रता पद्मनिलया पद्माक्षी पद्मकत्रका शिवानुजा पुस्तकभृत् ज्ञानमुद्रा रमाकरा कामरूपा महाविद्या महापातकनाशिनी दया मालिनी च महाभोगा महाभुजा महाकामोत्साहा दिव्याङ्गासुरवन्दिता महाकाली महापाशा महाकाला महाङ्कुशा गीता च विमला विश्वा विद्युन्माला च वैष्णवी चन्द्रिका चन्द्रवदना चन्द्रलेखा विभूषिता सावित्री सुरसा देवी दिव्यालङ्कारभूषिता देवी वसुधा तीव्रा महाभद्रा महाबला योगदा भारती भामा गोविन्दा गोमती शिवा
I'll now request Professor S.S. Kale to give the welcome address.
Professor P.N. Tandon, Professor Banerjee, Professor Bhatia, Professor V.S. Mehta, Professor Mahapatra, Professor B.S. Sharma, Professor M.V. Padma, who's on the dais as the Chief of Center. I can see so many professors and heads of department of different departments of AIIMS. My faculty colleagues, delegates, residents, nurses, the staff of AIIMS, everybody else who's here and I may have forgotten to name, I welcome you all to this, what can I say, a fantastic inauguration of this 24th annual microneurosurgery workshop. Apart from the inauguration of the workshop, there are two other things which I would like to announce here. One is there will be a book release. The Department of Neurosurgery has come together to write a book. It's a small effort. It's basically a case book. It just describes 20 cases of cervical spine trauma, and each case is described in detail, including the operative and the follow-up. And that each chapter follows a little bit of research, a little bit of review of literature, how the world, other people have dealt with each case. So it kind of, I as a junior surgeon, as a resident, I would have loved to have such a book. What exactly happens, what do you do when I get a hangman's fracture? Now, either you can go and read thick books and try to find, or you can have such a case book which tells you exactly how AIIMS does it. And I would have loved to have such a book when I was a resident. And so since the time I was a resident, my idea was to have a case book, which is probably the simplest form of a book one can have. But I guess for young people, it will be very useful. So that book is going to be launched. It's a combined effort of the Department of Neurosurgery. Almost every faculty member, resident, fellow, everybody has contributed. And I'm very grateful to the All India Institute of Medical Sciences. They have allowed us to use the name. So it goes by the name of AIIMS Neurosurgery Casebook. And hopefully, this is just the beginning of an entire series. There can be no end to this. We can have all kinds of pathologies, all kinds of regions. And I hope that this continues. And just like you have those clinics of North America, you have those books, and you can have 50 of them, you can have 25 of them. I hope one day that AIIMS Neurosurgery also has that kind of a series. So that book is going to be launched, and how much thankful I can be. I have never imagined a ceremony where 6 previous heads of departments of the same department are there, starting from the first till date. It is fantastic. I've never seen such and that's why I called personally and invited many of my friends and colleagues and other heads of departments, that I think this is a unique ceremony and we are privileged to witness this. We are privileged to witness this. So also with that, we shall be launching the AIIMS Neurosurgery presence on Twitter, and I think who is going to? Sachin is going to do that. He is going to tell you the details. AIIMS Neurosurgery will be on Twitter, and as the times change, we have to catch up, and a presence on social media, especially things like Twitter, are important. So that is also going to be launched today. So these 3 little parts of this ceremony. The first part, by lighting the lamp, we have traditionally started the annual microneurosurgery workshop, and now this will be followed by the inauguration of the book. Thank you all once again, everybody who is here. By the way, there is another hall where all this ceremony is being telecast live because we have some space constraints. So the other studio, there are some people sitting there and watching. So this ceremony is being shown there. So with those few words, I welcome you all again, and I call Manoj to carry the proceedings forward.
Now I'll invite Dr. Priya to. Pardon?
Dr. Padma.
No, not वो बुकेस और शॉल्स हैं डॉक्टर शर्मा को जाना है.
ठीक है.
डॉक्टर शर्मा को जाना है.
सर आप कहीं नहीं जा रहे.
सेट ऑफ लाइट है सर.
Anyway, Dr. Padma, बोलो.
Now I'll invite Professor Padma, Chief Neurosciences Center, to encourage us with a few words.
I have taken over so that you won't leave, sir. So, good morning. I would like to start this way. Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma, Tasmait, Sri Guruve Namaha. So, teacher of teachers, actually you were all my teachers too, because I've learned much more than neurosurgery. You taught me a lot about life, and I'll come to that, a little anecdotes later. And my friend and colleague, Dr. Kale, and dignitaries off the stage. Just few days ago, I heard this ecstatic voice coming from Dr. Kale's room. I went in to check what was happening, and there was this face which was brighter than 1,000 sun. And then he says he was whooping with delight, saying, "Fantastic, thank you so much, sir." And I asked him, what is it all about? And he says, Professor Tandon has agreed to come. And then he, updated me that there are these 6, the teachers who have been the brick and mortar on which the citadel has been built. Concept, even conceptualize, get the permissions and lay the foundation, and I get the entire cementing process to have this edifice and make it excellent, and also give you the batteries to charge forward and keep up that and raise the bar, all because of you. So each one of you. So that's that kind of an iconic moment. And then therefore this guy was super ecstatic, excited, and because it's seriously history which has been made, I guess, this day. And I'm so proud to be a part of it. Of course, this thing is just I'm at the right place at the right moment, but then I'm going to really, absorb this, and this is going to live with me for the entire life, because I don't think at any part in the world that I know of, and also maybe in the world, certainly not in India, that I've heard that in a department, when the teachers leave, they are just not welcomed, they're sought after. They're actually pulled and say, "Sir, please, you have to be part of our lives." I've not seen this happening in most departments across, and that's been a legacy that the Department of Neurosurgery has established, and the legacy I think we emulate, and I would hope that kind of thing is done across the universe. This is a really, really uniqueness of the Department of Neurosurgery of AIIMS Delhi. And I think that, again, it's part of the legacy that you all have established. Now, I'm not talking of microneurosurgery and all. You may wonder why I said teacher. So, Professor Banerjee, I don't think you remember, there was a day when, long back, when I was also little, and, you were going for your rounds, and then there were this whole bunch of monkeys, big monkeys, small monkeys, little monkeys, all over the place. And everybody just stopped. You were just walking, and I was there, and I was like, you held my little finger, you said, walk. And you told me that you don't look at those monkeys, because when you look at them, in their eyes, they feel it's a threat. You just walk across and they won't bother you. Ever since, sir, probably 25 years, I've done just that. And this is actually, this is a connotation, there's a lot more in life which you can draw parallel to that thing. And Professor Tandon, I mean, what can I say? I think there's in every step, whether it's professional and personal, you are one of, I turn to you and you have guided me. Professor Mehta, again, I mean, it's a personal connect with all of you, Professor Mahapatra. It's a joy to look at you. And this is what I really feel, it's from the heart. And so congratulations for this and this work of arts that, again, this is the very first. You're always getting these, firsts of even a dedicated book. It's not by one person or edited by somebody. This is a compilation of work of art by a department, and it's for the department, of the department, and, by the department. It's amazing. So all the best, and God bless, and thank you so much once again.
May I now request Dr. Priya to present a token of love, a plant and a shawl to our guests and teachers. Professor P.N. Tandon. Professor A.K. Banerjee. Professor Ravi Bhatia. Professor V.S. Mehta. Professor A.K. Mahapatra. Professor B.S. Sharma. Professor Padma. And Professor S.S. Kale.
तुम जाओ एक फोटो तो लो ना यहाँ पर फोटो ले रहे जो सार को करना था हम लोगों ने करा ना हो गया और एक
So as is the tradition of AIIMS, we are not just involved in patient care and research, we are actively involved in teaching as well. And we have come up with a case series book by the Department of Neurosurgery, as Professor Padma and Dr. Kale have said. And now I'll request our esteemed guests and teachers to inaugurate the book. सचिन को बुला लो। May I now invite Professor B.S. Sharma to share few pearls of experience and wisdom with us.
Honorable dignitaries on the dais and off the dais, seniors, friends. At the outset, I wish to thank Professor Kale and Vivek Tandon for inviting me for this function, and this has given an opportunity to meet you all after a lag of 2 years. And we all know that last 2 years were all COVID ridden, and this is the first opportunity, and Dr. Kale has utilized this opportunity very well, and that they have published a book. And this shows the dedication of this department. The young dynamic faculty, dedicated professors, and a phenomenal leadership by Dr. Kale makes this department unique. What is unique about the department and what Dr. Kale is taking is that he is following the traditions laid down by our seniors and taking everybody together as a close-knit department. I wish all the best and success for the future for this department. And this book release in the form of a case series is a better idea, because there are many theoretical books on spinal surgery. But this provides a decision making to the reader, and he knows the outcome and the follow of each and individual case. So I congratulate the department for the release of this book, and I hope many more will come in the future. Thank you very much.
Thank you, sir, for the encouragement. Now I request Professor A.K. Mahapatra to share his insights with us.
Jai Jagannath. I get the blessing of Lord Jagannath from Puri to all of you, our esteemed teacher, Professor Tandon, Professor Banerjee, Professor Bhatia, Professor Mehta, Professor Sharma, a beloved student and chief of the center, Dr. Padma, Dr. Madan, Dr. Gupta, Dr. Kale, all the faculties, Sonu, who has published that book, because without the publisher, book cannot be possible. I know Sonu for so many years, was time. It's a wonderful opportunity to get blessing of our teachers. Shraddhavan Lavate Jnanam, the Bhagavad Gita says. So anybody has interest, he can only learn. Without interest, there is no learning. And in another sloka, Lord Krishna talked to Arjuna, Tadidhi pranipatena pranipprasnena sevaya upadesyanti te jnanam jnaninam tattvadarsinam. Teacher is not only give lectures, online lectures. That's probably the worst form of teaching and education. Teacher is a mentor, is a pathfinder, is the father, is the motivator, is the stimulator, and after all, is the guru that take away the darkness of student and make it enlightened. We are indebted to our teachers because they have given us right knowledge, right perspective, right direction, right vision, and right future. We are always will remain grateful to our teachers. So today is a historical day in the Department of Neurosurgery because such an occasion will not come when all of us are there. We never had any difference of opinion. I work 42 and a half years. I don't know how. When I come to Delhi, I think Delhi is something new for me. I sometimes say, what? I have got lost in last 4 years. Delhi looks to me absolutely new. From airport to AIIMS, every day there's some changes. So I don't know how I spent 7.5 years in the hostel and another 35 years or so in the campus from Ayurveda Nagar. Dr. Mehta and me were staying in Ayurveda Nagar when these houses were made in 3 months' time. Dr. L.P. Agarwal say after the student strike, Dr. Mehta is laughing because we used to come, how difficult is from communicating, coming from Ayurveda Nagar, 3 kilometers those days, looking like 300 kilometers. I remember the day when Mrs. Gandhi was assassinated and I was on call that day. I had to walk from here because there is no way from going here to Ayurveda Nagar and saw South Extension, Masjid Mode and all places are burning at 7 p.m. Wonderful. Something is good, something bad, something enlightening, some depressing. Life is full of ups and downs. We have gone through it and you will go through it, but it's a learning experience. If mind is open, eyes are open, ears are open, we will learn. If you have no interest, no amount of teaching, no amount of books, no amount of knowledge, I now see we give thousands of online education. We have 15,000 students in our university. But when you take exam, 50% fail. I was telling Dr. Anand, Dr. Banerjee, in first MBS, 50% fail. I say, wonderful teachers, wonderful technique, wonderful knowledge, but student failed. Why it is that? Shraddha, interest, love for education, love for knowledge. You may think why I am telling that. Nobody can learn without interest. So you have to create interest, see the right thing. I think all of you saw 3 Idiots. 3 Idiots. Now we are telling credit points. It's not classroom teaching is enough for education. That's minimum necessary for passing an exam. I give talk from nursery to postdoctoral fellows because you have to different standard for different people. And it is not education that you give a lecture, somebody comes and write up. It's a lifelong journey of learning. I think Sir Saratel, we had in a Sydney conference of WFNS and Dr. Ramurthy came to a dinner party. And me and Dr. Segal and Dr. Aditya Gupta sitting there and he came, I don't know, depressed, happy. I thought he's going to shout us out because we have done something mistake. But he came and told us, boys, we just stood up. Dr. Segal, me and Dr. Aditya Gupta in a dinner party. That was September 2021, just after the Twin Tower has fallen to that attack. So he said, boys, I'm getting old. You have to take in the charges of neurosurgical training and research in this country. I am now 82 years. I think maybe I will not be able to attend any more conference. And that next year, 2022, he passed away. And we were thinking that why he's coming at 10 o'clock night to us, must we have done some mistake. It's not. It's the teacher has always good intent of the student. Whatever rude he may be, whatever he may sounds, there is always internal feeling that my students should excel. Sir, I thank you very much for your blessing. I am here today because of your blessing. Thank you very much. Thank you.
Thank you, sir. May I now request Professor V.S. Mehta to address us and encourage.
Thank you. Respected
Dr. Tandon, Dr. Banerjee, Dr. Ravi Bhatia, Dr. Mahapatra, Dr. B.S. Sharma, Dr. Kale, and Dr. Padma. Well, it's my great pleasure to be here. And I must say that this department has great grandfathers with us. Your great children are still there and they are doing very good work. And it gives a satisfaction to each one of us that we have our great teachers, and all because they had laid down the foundation so strong that it continues and continues. And I must tell Dr. Kale that he is doing a wonderful job by publishing such a book, and it is going to be very useful for each one of us. Thank you very much, Dr. Kale, for inviting us. Thank you.
And thank you, sir. May I now request Professor Ravi Bhatia to speak a few words? So,
Call this.
Dr. Kale, Dr. Suri, and all the wonderful colleagues, thank you very much for asking us to this fabulous function. It's difficult to imagine how the department has really grown and what wonderful things you've done. And may I, on my behalf and my wife's behalf and my children who spent a lifetime here, thank you for being wonderful colleagues and altogether a wonderful occasion. Thank you.
thank you, sir. May I now request Professor A.K. Banerjee to address us?
Well, good morning. Before I come to the book release and this function, I must say it gives great pleasure to hear such pleasant things about yourself from so many people, Padma and Kale and of course everyone. Very pleasant feeling. One tends to believe it, for some time that they must be true. Then within a few seconds, of course, one falls again back onto the chair. That these are just hyperboles. They are said for the occasion. But anyway, no, thanks, Panna, because I taught you never to be hostile to anybody. Never be hostile. I think it's a great occasion to be back in the department and our department. That's the biggest tribute, that even after retirement, if you say our department, then that says a lot, So it is again like coming back to your own house. I think what this workshop, many of you may or may not know, was the brainchild of Dr. Mehta. And it requires a tribute from all of us that, he was able to do it, because the only workshop at that time which was running was at Chennai by Dr. Ramamurthy. It is still running, and we are also running, although we started later. And the difference between the two was one, and that is we opened the windows and doors. We not only had Indian people coming here to demonstrate their skills and competence, but we also opened the doors to people from outside. So there are many people from outside who also came and developed, helped us develop, as well as the whole country and all the people who
join these workshops, develop their own expertise. And that's a great thing. I was only this morning saying that once if you see somebody actually doing it, not the films, not the book, not the journal article, but actually doing it, then the first thing that one feels in one's own self is, if he can do it or she can do it, why not me? What's special? And that is where these workshops have been a great thing to push things forward, push forward your internal strengths which you didn't know, and suddenly you are able to do them. As far as the book is concerned, I'm so terribly happy to have a book which the whole department has contributed. It's a great thing, I think, and I wish that it continues, grows in strength, and as this time you have done cervical spine, you should be able to do others, because this will be real teaching in that sense of the word, which Dr. Kale had referred, that once you read it, you know that if this type of thing comes, this should be my approach. Approaches will change. As things improve in technology, things will change. But nevertheless, this is a very great beginning, and God bless this beginning, and shall we say, Lord Ganesha's blessing be on it. Thank you.
Thank you, sir. May I now request Professor P.N. Tandon to speak a few words and encourage us.
First of all, I believe ladies first. I don't know, she is chief, of course, but I've always considered her as a daughter. Dr. Kale.
Granddaughter.
Yeah, granddaughter. Granddaughter. Correct. I'll come to that. You see, I've always followed Dr. Berger. He has not followed me. That's a tragedy. He just made a statement that all the praise that you have heard may sound very nice now, but later on. I tell you a story as usual. That's all I have learned to do. There was a priest who was praised endlessly in the introduction. When he started to speak, he said, "Oh Lord, today I have to say 2 prayers." Everybody said, "What?" One, for all the lies that have been told about me. And number 2, for I to have enjoyed it. So that's what it is. And Mahapatra always gives a hint always. I always look up to him, and even on telephone he will tell me something very nice. He said about the grandchild. You see, my father used to say, मूल से प्याज ज़्यादा प्यारा होता है. That means you love your grandchildren more than your children. So Padma is not, you happen to be that age, I can't help it. Now, I requested Dr. Kale, if he wants a book to be released, I want to read it beforehand. Dr. Kale, whole day yesterday, I've read through your book.
I hope it makes some sense.
I'll come to that. The most important sense that it makes, we'll come to it in a minute. But I want to first tell this audience, the Department of Neurosurgery as of today, including Dr. Mahapatra's dozens of books,
has published more than 40 books. So what is so new? Another book. Yes, there's something new, which if I had not read through this book, I wouldn't have recognized it. So he said, "Kaise bhejunga?" And I got a little upset when the book reached me at 9 p.m. day before. And the person who brought me, I had to unlock the whole house to open the door for him to get the book. So I lost a little bit of my temper. The most important single thing is that's a book not by an individual, but by a department. A department which has carried a tradition to involve everybody. And like an old grandfather, another advice. We have to now extend it. Cervical spine or any doesn't restrict to neurosurgery. And next time we should involve all other collaborators in the institute, neurologists, orthopedic surgeons, or ENT surgeons, depending on the book that you are writing, so that it becomes a truly all India institute book, which the department has always believed in. We always said that the tradition of the department was always one, the country above the institute above the department, and the department above every single individual. And nothing is more heartening to me than to see this tradition continue. It has been said by some very reliable people. I may be quoting Dr. Banerjee, for example, because we use every week, that in this country, the half-life of a department or institution or a university, I'm not meaning at all to you, Dr. Mahapatra. No, they keep it 15, 20 years, maybe 20, because I belong to another university indirectly through my father, Dalabad University, that did make 50 years. The Department of Neurosurgery has crossed 50 years. It's still surviving, flourishing, doing better than what it was doing 2 years ago, much better than it was doing 5 years ago, and much, much better than it was doing when I retired. So that is the greatest pleasure anybody can have. And last of all, you have all referred to me as a teacher, and I confess that nothing I love more, even more than neurosurgery, is being a teacher. But who can be a good teacher? That I learned from teacher of all teachers, Osler, who said, a teacher is successful only when he has students who are better than him. And I think today, at this historic day, I can say that at least whether I succeeded as a neurosurgeon, as a chief of neurosurgery or not, but I believe, I trust, and without having to say prayers for it, that in one thing I am proud of is having the most outstanding students one could ever have. And they keep on teaching me even today, as Dr. Kale and his colleagues did. Thank you very much.
Thank you, sir. Your words mean a lot for us. We are indeed like branches and leaves and maybe the fruits of a grand tree, which is probably you. So may I now invite Professor Dr. Vivek Tandon, Organizing Secretary, to propose the vote of thanks.
Thank you, Dr. Manoj. It's indeed a very momentous and emotional occasion for all of us. कबीर ने कहा था, गुरु गोविंद दाऊ खड़े काके लागू पाए, बलिहारी गुरु आपने गोविंद दियो बताए. तो जब गुरु हो तो उनके ही पांव लगना है. और आज इट्स अ वेरी स्पेशल ओकेजन बिकॉज गुरु के गुरु भी आज हमारे समक्ष हैं. I don't remember, I think in last 15 years, I've seen, sir, all of you here. And it makes us very proud that all of you have come here to bless us. I've been asked to offer vote of thanks. And I think it is the most difficult job because there are no words which can describe our gratitude, our indebtedness to our teachers. Sir, we are what we are today because of your vision, because of the teachings that you have imparted us. We are really grateful to all of you. I would like to thank Professor Tandon, Professor Banerjee, Professor Bhatia, Professor Mehta, Professor Mahapatra, and Professor Sharma, who has left, for taking time out of their very busy schedules and taking so much of pains for being here for us. I would like to thank our Chief of the Center, Professor Padma, for being here and being a constant support and source of encouragement for all of us. I would like to especially thank Professor Kale, who has been a pillar of support for us. He has been encouraging us and guiding me throughout this journey in last 1 year. He has been taking care of all the nitty-gritties. Whenever I used to think that I've planned everything well, he will point out a small mistake there. Thank you, sir. I would also like to thank Professor S.K. Gupta, who has come all the way from PGI Chandigarh and accepted our invitation to be the orator for A.K. Banerjee Oration, and he will also be operating and teaching us the finer nuances of surgery. The workshop is held every year. This is the 24th edition, and many of you won't be knowing, but there are many departments who collaborate and they help us. And for this, I would like to thank each and every department. I would like to thank Department of Neurology, Department of Neuroanesthesia, Professor Chaturvedi, Department of Neuroradiology, Professor Shailesh Gaikwad. I would also like to thank Professor Meherchand Sharma, Department of Pathology. Sir, without you, how will we get to know the biopsy during the cases? Professor Ashok Jaryal, he helps us in all the physiological monitoring so that we have been doing. I would also like to thank all my senior faculty members, Professor P.S. Chandra, Professor Ashish Suri, Professor Manmohan Singh, Professor Rajendra, Professor Deepak Agarwal, and all my fellow colleagues and students and faculty members who have contributed immensely. I can't thank them enough for their cooperation and contributions. I would also like to thank all the paramedical staff who will be working behind the scenes to help all the patients who will be operated during the whole course of this workshop. Members who are there working in the ICU, operation rooms, even the labs, they will be taking care of all of you. I would like to also thank all the delegates. You will be surprised, sir, we had to close the registrations. But despite shifting the conference after the COVID, we have so many people who are here, not only from India, but also from the other countries, neighboring countries, Nepal, Bangladesh, Sri Lanka, Maldives. I would also like to thank all the heads of the department who have come for the inauguration of this book, Dr. Shiv Chaudhary, Dr. Khaitan, Dr. Agarwal, and the senior faculty members, Dr. Sushma, who have come here for this inauguration ceremony. I would also like to thank Salubris, who has helped us compile the whole book for this. And nothing is complete if you don't thank the sponsors because of whom we are holding
this show, they have not only contributed economically, but they have provided us with the technical support. When you will go out of this hall today, you will realize that there are many stations which have been built to help you have some hands-on experience and gain some new skill. And it is because of the sponsors who have brought such very expensive equipment for all of you. I would also like to thank our back-end team of Vipin, Shweta, Batraji, Ravinder, and everyone who has contributed immensely for the conduction of this workshop. I'm sure I must have forgotten many names, and I'm also sure you will pardon me for this. With these words, I would like to invite everyone for the high tea, and we will conclude the inauguration ceremony here. But for the delegates, we have divided you into various groups and batches. You can go to the help desk and you can check where your number is, and you can go there. And after this, we will start live operations and the transmission from the OT here in this hall as well. Thank you very much.
Thank you, everybody. I invite all of you to join us for high tea in the cafeteria in the same floor, same building.
Thank you. Thank you. ये मैंने करवाया था ना, तुमने नहीं करा था।
Ashish?